So let's see more in detail about nerve injury. When we talk about nerve injury, first of all, we need to understand what's happened to the nerve when it's injured. This is a normal nerve that is involved in create neurotomesis, so the nerve is completely interrupted. What's happened? The first reaction of the nerve is to allow the proliferation of the Schwann cell to create a sort of a railroad that allow the new axon to reinnervate and recreate the connection from the proximal to the distal part of the nerve. If we see more in detail, that's what's happened. Is also called the Wallerian degeneration. So when there is the nerve lesion, there is an inflammatory reaction that creates a macrophage proliferation that's clear all the debris of the nerve, and a Schwann shell proliferation that is not how can I say, casual, but it is well organized. And in fact, we can see at the microscope view, they are well organized to create a railroad called bands of nerve that give direction to the nerve to reach its target. In this case, it is a muscle fiber. To allow that nerve join its target, there are two properties we need to know. The neurotrophism. So the nerve reacts to growth factor that allow is growing and so to reach its target. And neurotrophism. So the nerve is able to find home. Obviously, you need a railroad created by Schwann cell, and is able at this way to find his way to home. Mechanism is actually very important when we examine a patient with nerve injury. It's the first thing we need to ask the patient, how did it happen? Because based on the mechanism, we can have already an idea what we see, what we have in terms of grade of injury to the nerve. And we need to distinguish immediately between penetrating injury and blunt injuries. Penetrating injuries are sharp laceration injuries or gunshot wound injury. Sharp laceration is a open injury like a gunshot, but in this case is a sharp laceration. The most usual reason is use of the chainsaw machine. Happened that when these men use the chainsaw using the extremity, the chainsaw act like a jump out, and so there is the reflex to push the forearm in front of the face to protect. So the face is safe, but the forearm not, and even the ulnar nerve is not safe at all. In fact, we can see here there is a neurotomesis. In this case, the exploration is mandatory within 3 days, because after 3 days there is a lot of scarring, there is a retraction of the nerve, and so to find the extremity of the nerve is very difficult unless somebody has a very well knowledge of the anatomy, but it complicates in a bad way the surgical work. So it needs exploration within 3 days if we got a sharp laceration. If we got gunshot wounds, the repair could be delayed for 3 weeks. Why? Because gunshot wounds are very rare, can create a neurotomesis. Usually it creates a stretching against the nerve. So in this case, it happened that the nerve develop neuroma. Neuroma is literally a scar into the nerve, caused by node reorganization of the band of Bugner, and so this new fiber regrow in a not well organized fashion, and so this the result is neuroma. In fact, we can see here two sections, proximal distal, that are very well done with normal architecture fascicle of the epineurium. Here there is a totally loss of the architecture. But we need to wait 3 weeks, because sometimes the nerve is able anyway to recreate its connection. So after 3 weeks, we perform a new exam, clinical and electrodiagnostic, and we see if there is a reinnervation. We need, in fact, to remember that the majority of upper extremities shot bone injuries spontaneously recover between 3 and 6 months. Blunt injury are, for definition, closed injury. One of the most common is crush injuries. Crush injury is related to increased pressure, like could be hematoma, edema, or fracture, and the most part are managed non-operatively. The only reason to explore crush injuries is when there is needs surgery for the reason, like could be fracture. In this case, we explore also the nerve during the surgical procedure for fracture fixation. Or could be stretch injury or traction injury that are often associated with high velocity or high impact trauma. As the most common example is motorcycle. In this case, there is a stretching of the root, but without avulsion. When happen avulsion, this is definitely a damage that needs surgery, and we see in the following slide how it could be managed. And this is a picture that well describes what consists in the avulsion. So for every one of these mechanisms of this nerve lesion, many authors attempted to create a classification. The first one was created by Seddon to distinguish neuropraxia, axonotomesis, and neurotomesis. Neuropraxia is talking in terms of pathology, is a ischemia of the nerve. The nerve is compressed, caused the injury, and loss is myelin sheath. But the axon is still in continuity, and that's the main aspect of the grade 1 or neuropraxia. When we talk about axonotomesis, we have an interruption of the axon, but it's needed to going deeper to this definition with the Sunderland classification that distinguish a second, third, and fourth degree for axonotomesis, because axonotomesis is, of course, interruption of the axon, but in grade 2, there is still a continuity of the perineurium. This is this violet line here. And there is also a myelin aspect that helps the nerve to find his home, his target. So in this case, neuropraxia and axonotomesis, second degree for Sunderland, is a favorable injury because the recovery usually happens. If we go to the grade 3, in this case, we have lost also the myelin. So the recovery is, in this case, partial slow, because there is a loss of myelin, loss of Schwann cell, and let's see more in detail what consists in the Schwann cell. And what's the meaning of Schwann cell in the nerve growing. When we got a grade 4 and grade 5, well, situation is very complicated because in this case, there is interruption of the perineum. So the nerve there is high probability to have a neuroma, but a regrowing, a regular regrowing. So in this case, usually reinnervation don't happen as needed as surgical exploration. Grade 5 neurotomesis is definitely for surgery. In this case, nerve don't recover because there is a completely cutting of the nerve. So the nerve is not able to recreate this connection unless there is a surgical exploration and surgical repair. And we cannot forget the chronic nerve compression that is usually caused by entrapped nerve syndrome that I hope to talk in my following panels. Chronic nerve compression consists in a chronic compression, of course, and what's caused if we have a look into the nerve. It creates at the first a subperineal endoneural edema that create going more and more ahead a perineural and epineural thickening and change in connective tissue. So it creates a low flowing to the nerve. Just remember, since now that the nerve need vascularization, need blood, if the nerve don't receive, the nerve don't regrow or regrow in a bad way. And going ahead, this causes a stress to the fibers that cause a clinical result that can going worse, going ahead, cause there is a valvular degeneration. Valvular degeneration means deficit of the sensitive and motor aspect. And we can see more in detail what's consisting in chronic nerve compression looking at this picture. Here on the left, we got a section of a normal nerve with all these axon. It is a sky star, we can say. But here is a section of nerve with chronic nerve compression advanced. And so we got a loss of axon. That's the result of chronic nerve compression. We need to remember also that to allow a regrowing, a reinnervation after a nerve lesion is just not enough to have a classification grade, but we need also to remember that many factors affect the outcome. First of all, the age is definitely in literature that age and in particular people over 60 years old have less regrowing. In children, regrowing is a very fast, relatively, of course, but it's happened also because children are little, so there is less distance than in adult people. Smoking is absolutely very important because in a negative way, of course. In fact, I tell always my patients when I have to perform a nerve surgery, if you smoke, please stop smoking because the nerve has a little vessel. If you close this vessel, smoking, the outcome cannot be a good outcome. And obviously other pathologies like diabetes, hypothyroidism, and peripheral vascular disease can create a problem of ischemia, can condition the can involve the outcome. And another things is very important, the therapeutic and rehabilitative compliance of the patients. So the patients need to know since the beginning that after peripheral nerve surgery, in particular if consists in nerve repair, you need to perform physical therapy and be constant. If done is not compliant, the opportunity for the nerve regrowing are less. And let's talk a little bit about the clinical examination. Is just a brief description, because it's my intention to give a more deeper description when we talk about in the future panel about every single nerve. Talking in general, we need to examine in a patient with symptoms and suspect of peripheral nerve injury, sensory. Let's perform provocative test. Let's examine the motor strength, and let's examine also the subjective symptoms like pain, evaluation, and the quality of life. That's very important. Sensory evaluation need to evaluate the quickly adapting receptor that are the light moving touch that can be examined by 10 test. 10 test is very simple. You touch moving and touching, in this case, the second finger. You say the patients if there is a difference between the healthy side and the affected side. Healthy side is 10. The affected side should be less than 10, and the patient is able to give a score in this way to the nerve lesion. And vibration. Vibration needs the diapason to examine the vibration. A slowly adapting receptor are the receptor that carry on the cutaneous pressure feeling, that could be examined by the Weinstein monofilaments are we see here more detail. The filaments with variable diameters, and so touching at the pulp of the distal phalanx, we are able to examine what's the threshold of the patient for cutaneous pressure. Two-point discrimination could be done by the discrimination. Is a tools created by Susan McKinnon that examine the two-point discrimination. That is even this related to the slowly adapting receptors. Provocative tests. Provocative tests are very important because they allow to give us an idea where is the site of injury. Obviously, in case of lesion like could be the chainsaw we just seen, the site of the injury is obvious. But when we talk about, in particular, nerve entrapment, the provocative tests are very useful. We got here a list of provocative tests more common. Probably the most common, and everybody of you know, is the Tinel test. That is very useful in the examination of patients with suspect carpal tunnel syndrome. Pushing repetitively in the correspondence of site of entrapment, common site of entrapment of the nerve, we are able, if there is entrapment, to evocate the neuralgia. On the contrary, for a more proximal aspect, like would be for outlet or thoracic syndrome, we can use the Ross test. The Ross test, the patients put his upper arm in this fashion, extra rotate the wrist and the forearm, and starts to close and open the finger. This test is able to recreate the brachialgia, the neuralgia to the upper arms in the site of outlet thoracic syndrome. Motor strength evaluation need two things. First of all, an observation of the patients. We need, like it would be in this case, to see the patients. So get naked the patients, don't be afraid, and examine the patient. In fact, you can see here in this patient, there is a definitely atrophy. In fact, here on this side is normal. Here there is an atrophy of the deltoid of the bicep brachialis, and there is also a scar. So the patient was involved in injury that's probably caused a lesion of the suprabrachial aspect. In this patient here, we got a very common atrophy, that is the interosseous dorsal atrophy, that usually caused by ulnar nerve involvement. And in this case, a typical finding in patients with brachial plexus injury, and in particular long thoracic nerve injury, is the winging scapula. And another thing we need to examine by observation is the symmetry of the atrophy. In this case, there is no an asymmetry like could be in this patient, but there is atrophy in both the sides. In this case, and in particular, if we ask the patient if there is history of trauma, he probably said not. There is no reason to suspect nerve injury, but preferable there is a neuropathy. In this case, is a Charcot-Marie-Tooth syndrome, that is a motor neuron degenerative syndrome. And to get a score to the motor strength, we got the most common scale used, that is the Medical Research Council of Great Britain grade, that examine from normal power until no contraction at all at the 0 score. The pain evaluation is obviously a symptoms, and there is no an instrument that can give a score. So it's the patient by himself or herself that need to tell us how consists in his pain, and usually is very helpful to ask the patients first of all, and then tell him or her to give us a score using the visual analogous scale. And another thing, the DASH score is a self-report questionnaire, very useful, but there are a lot of these questionnaires that help us to examine the quality of life of patient. And so it's very helpful when we examine the patient aiming to propose, to find a surgical solution for his problem. So let's have a look now to the electrodiagnostic examination of patient with peripheral nerve symptoms. That's the only instrument I talk in this lesson. I won't talk about imaging tools like could be MRI, because usually MRI is helpful when we have a suspect of a nerve tumor, or we need a differential diagnosis with, for example, a cervical discal hernia. But it is rarely useful for nerve injury or entrapment nerve syndromes. And about sonography, sonography is becoming very helpful every day in peripheral nerve injury. So it's my intention to dedicate one panel to the sonography for peripheral nerve pathology. So let's have a look now to the electrodiagnostic examination. When we talk about electrodiagnostic examination, we need to remember that nerve can have two sorts of injury in terms of pathology. The Wallerian degeneration that can create a conduction failure, a conduction block, or a conduction slowing. And the demyelinization, so where the axon is safe, that can create a conduction block or a conduction slowing, but not a conduction failure. So let's see the electromyography. Electromyography is an exam that value the muscle and so indirectly value the nerve. Electromyography is divided in three sorts of examination. The first one is insertion phase. insertion activity we register is when we put the needle into the muscle. When we put the needle into the muscle, we got immediately an activity that is the normal feature. It is called insertional activity, that usually is a frequency of less or equal to 300 milliseconds. There could be a decrease of this activity, and that's happened in two cases. Or we put the needle electrode in a bad way, so it's not into the muscle, but is in the fat or in connective tissue, or is the same muscle that is fat or connective filled, so is a degenerate muscle. In this case, we got here a less frequency of insertional activity. When we have increased insertional activity, usually is caused by nerve lesion and could precede by 1 week another aspect of electromyography that are the fibrillation potential. In this case, we got an increase of insertional activity. The second step of the electromyography examination is the rest phase. So we just put the needle and we got the insertional activity. Now, let's leave the patient with the needle for a few seconds, telling him to don't contract at all. And usually we got just a line. But sometimes when the needle is put very close to the neuromuscular junction, we got these two potential that are not fibrillation potential, but they are end plate noise or end plate spikes. In this case, probably this picture don't tell you anything, but when we see how are the fibrillation potential like, you got an idea. And so let's see the fibrillation potential. Fibrillation potential are very important finding when we talk about nerve injury, because when we got motor axon loss, there is a fibrillation potential definitely, and this happened after 3 weeks after the nervation, and that is the how they appear. The first one is the first fibrillation potential that are spike. It is the first phase, but when is happened that the denervation still stay, there is an increase of fibrillation potential, and thus the feature is a well-defined feature of motor axon loss. We can also have fascicular potential, but they usually means irritability related to denervation, and they are very little important when presented in isolation. Usually they could be found in axon loss lesion, but also in chronic demyelinating process or thyrotoxicosis. And this is how they appear. They are usually have this feature with a triphasic way. Or we can have complex repetitive discharge that happen after 6 months after the lesion. In fact, they are very uncommon acutely, and how they appear. They are caused usually by a connection of potential between fiber muscle. Fiber muscle, in fact, they are able to transmit its potential to other fellow around, creating a CRD, complex repeated discharge circuit, and thus the result. Other aspects of spontaneous activity are the myotonic discharge, but usually caused by disorder of the muscle membrane, so not a common finding for the peripheral neurosurgeon. And they have this aspect with an increasing and decreasing potential. Group repetitive discharge, they are this, and when they group, they are also called myochemia, and usually finding in radiation-induced brachial plexopathy. Crown potential are strong associated with fasciculation potential. In this case, it's very important to ask the patient if he got a pain, because they got this aspect. we see here more in detail. In fact, we got a 100 millisecond of in this picture. Going deeper in examination, we can see here they have a well-defined aspect, and usually are caused by cramp potential. So if you got here this picture and the patient say he got pain, is definitely cramp potential. And then we finally came to the activation phase. Activation phase is a phase where we can see the MUAPS. MUAPS means motor unit activation potential. We are stimulating the muscle, and so we got a contraction, an activation of the motor unit. And with light contraction, we can have once or two motor unit action potential that usually got this feature with the Mayer spike, usually serration, and usually there is also a satellite potential that is more can be more see when there is a renervation. We divide this potential in phase when we cross the zero line. So first phase, second phase, third phase is a triphasic potential. And when we ask the patients to increase this force, so we ask the patient to contract his muscle more and more, there is an increasing number of motor unit action potential. So is also called spatial recruitment, and they begin to fire at faster frequencies. So there is also temporal recruitment. That's what consists in the normal activation phase. And when they reach the maxima maximal contraction, we got motor unit action potential that are indiscernible. So is also called the full interference pattern, FIP. What we can have in this phase of pathology? We can have early recruitment that's happening in myopathies or nerve muscular junction disorder. So it's very common for the surgeon of peripheral nerve. And this is the phase you can see is very there is a disorder of potential because we got a recruitment of potential that overcome another potential. So it's very, very not order. We can also have a reduced recruitment. In this case, it could be caused by axon loss or demyelinating conduction block. And this is what's happened. We ask the patient to contract. We don't have this interferential pattern, but we have this, so reduced recruitment. And in fact, we got fewer motor unit action potential that fire at faster rate. In this case, we got a discrete interference pattern. And this is a picture of discrete interference pattern. And in this case, in particular, there is we can see a discordance between spatial and temporal recruitment. We got a spatial recruitment, but not temporal recruitment. So it means is neurogenic recruitment. And very important is because sometimes, and that's the problem for the electromyographyist, the patient came to us telling he feel weakness, he not able to contract. But if we examine the patients and we suspect malinjury, we just need to check the activation phase. And if there is spatial and temporal recruitment concordant, definitely there is not a nerve lesion at all. And so it could be caused by pore force, pain on activation, hysteria, but not by axon loss or demyelinating conduction block. Other feature of nerve lesion in electromyography are remote motor axon loss that create collateral sprouting. We just seen how the nerve can regrow after a lesion, and thus mean increase in motor unit action potential in the electromyography, also called chronic neurogenic changes. Or we can have the myelinating conduction block. In this case, the motor axon remains in continuity with the muscular fiber. Collateral protein does not occur, is not needed because the axon is in continuity, and so we cannot have affection of the motor unit action potential. In a complete motor axon loss lesion, like would be the Sunderland 4 and 5th degree, collateral split can occur. We just seen how in a neurotomesis, the nerve is not able to regrow. So it's not able to recreate the motor unit action potential. In fact, we don't have motor unit action potential. It's very important to check because there could be a reason to explore the nerve, because it is helpful to have a diagnosis of Sunderland 4 and 5th degree. And that's a picture that resumes what we just say. This is a normal potential, not a normal motor unit action potential. When we got a neuropathic, we got obviously alteration of the potential with regrowing, so there is an increase in motor unit action potential, we can see here. But when there is myopathy, it's not usual for a nerve injury, so for a surgeon of peripheral nerve, but with myopathy, there is definitely a decreasing. So it's very important to remember this. When we have a regrowing of the nerve, the normal potential, because more than normal, we can say, but it's not normal. There is a neuropathy because it's nerve that are attempting to regrow and to re-nervate its target, its muscle. And with this, there is myopathy. The nerve can regrow what he wants, but he's unable, he don't find a true target. So it's myopathic motor unit action potential. So let's keep in mind that when we talk about electromyography cannot discriminate between the Sunderland 2nd and the 5th degree of nerve injury until collateral sprouting, so the motor unit action potential occurs. So we need to delay the electrodiagnostic exam, and in particular electromyography, until 8 to 12 weeks. And the clinical manifestation of nerve injury typically are maxima at the onset, but if we have an exam, electrodiagnostic exam at the onset, the electrodiagnostic manifestation, there are not, and not able to tell us a diagnosis. So we need to delay the nerve conduction study for more than 2 or 3 weeks, 5 weeks, if we want to check for a full development of this manifestation. And let's finish talking about nerve conduction study. See, the electromyography help us to understand by examination of the muscle if there is a problem, pathology to the muscle or to the nerve indirectly. Nerve conduction, so they examine directly the nerve, stimulating him. Nerve conduction study are 3 types. Sensory, they examine the sensory nerves. Mixed, when they examine a nerve that have both sensitive and motor component, like could be ulnar nerve or median nerve. Or we can also examine just motor nerve, like for example, the posterior interosseous nerve. When we perform an exam of sensory nerve, we need to remember that the anatomy. We need to remember that the sensory nerve consists in a dorsal root ganglion with a proximal part and a distal part, but the cell is into the ganglion. So when we examine this nerve, we are able to have a potential that's examine this part of the nerve. If we have a root avulsion, the nerve conduction study is not able at all to tell us if there is an avulsion. We can perform these nerve conduction studies of sensitive by orthodromic or antidromic technique. Orthodromics means that we give the stimulus to the nerve distal, and then we examine by receptor electrodes in the proximal aspect. So we follow the normal action potential of the sensitive nerve. Or we can also use the antidromic technique, because we need to remember that when we stimulate a sensitive nerve, the potential going proximal and distal. So we are able to examine also by antidromic technique. In my activity, and most part of the culture agree, the antidromic technique is preferable. It's preferable because it is less uncomfortable for the patients. That's one of the reasons. And the nerve action potential are higher, but sometimes it could be a problem, because since the entire nerve is stimulated, if we have a mixed nerve, we can also stimulate the motor action potential. So in this case, we can see there is a potential, but we're not able to say if it's motor or sensitive. There is the doubt. In fact, in this case, it's preferable to do both the orthodromic and antidromic techniques. The sensory nerve are indispensable part in this examination for several reasons, because they are the only examination able to examine from the dorsal root ganglion to the distal aspect. So they have a localizing value, as I just told. And then the sensory nerve conduction study are more sensitive than motor nerve conduction study, identifying focal demineralization and axon loss lesion, like could be in carpal tunnel syndrome. And the major drawback of sensory nerve conduction study is the small size of recorded responses, and in particular, individual over the age of 60 years. Sometimes this patient, we can have absent lower extremity sensitive nerve action potential. So just to remember that. When we perform motor nerve conduction studies, so compound motor action potentials, we need to do an orthodromic technique. We cannot do an antidromic, because motor nerve conduce just distal, and we need to examine the contraction of the muscle. So we need to put the electrode examination in the muscle and his tendons. We can do two record, and we can do a proximal and a distal record. We need to do both every day, because using proximal and distal, we are able to get the conduction velocity. Just remember that when we stimulate a nerve, we got the potential to the muscle after there is nerve stimulation, nerve muscular junction conduction, and muscular fiber conduction. So we need to get a differentiation from proximal to distal, so eliminate mathematically nerve muscular junction part and muscular fiber conduction, and so we got it through velocity conduction. We got here an example of potential, nerve action potential, and in particular the feature of this exam, the amplitude. Amplitude is very important, because with areas that usually is calculated automatically by the machine, is able to tell us the number of functioning nerve fiber. Latency actually is underestimated through condition velocity, so it's not fundamental for the peripheral nerve surgeon. Conduction velocity obviously is dependent by the distance stimulating, but usually putting proximal and distal electrode, we are able to have a good idea of conduction velocity. And duration. Duration is this, and it is very important because it is a feature of the demyelization. If we have a slowing of duration, we need to suspect the demyelinization. But when we have a demyelinization, usually the amplitude is the same in the area as well, because the myelin is lost, but the axon are still there. So usually the amplitude is normal, but duration is involved in demyelinization. And let's see more in detail what demyelinization consists in. This is a normal exam of the in nerve conduction studies with the two potential, proximal distal. But when there are axolemma exposed, there is a demyelinating conduction block. So in this case, red light, there is a slowing and an increased, we can see, of duration with prolonged latency, slower conduction velocity, and temporal dispersion, because we got here a loss of synchrony and so temporal dispersion. When we got axon loss, it is very important to remember, because the compound motor action potential begin to decrease in sites around the second, third days. We can see here this line of compound action potential, and they reach the nadir at 7 days. So that's because doing nerve conduction study immediately after the trauma is not helpful at all. And when you got snap amplitude, usually they diminish after the motor action potential at 5-6 days, and they reach their nadir around 10 or 11 days. So keep in mind just two things, that focal demyelinization basically don't give electromyography abnormalities. It could be fibrillation potential, because most symptomatic in demyelinization conduction block lesion are associated with at least a few disrupted motor axon. And due to the high innervation ratio of most skeletal muscle, this few disruption might be associated with a large number of fibrillation potential. So sometimes happen that we see fibrillation potential and we say, oh my God, there is axonotmesis. No, sir, there is just a focal demyelinization, and there is, in fact, could be a fibrillation potential. So we need to re-examine the patient and see if there is still fibrillation potential, or we got motor unit action potential, or we got restitution integrum of the signal. So in this case, chronic neurogenic motor action potential chains don't follow. So if you have just a focal demyelinization, because the axon still is safe. When we got axon loss, we can have mild axon loss. So we got fibrillation potential, and we just seen sensitive and motor action potential amplitude decrease, and neurogenic motor action potential appear. We got here a well done example with a normal potential, but when there is axon discontinuity block, we got a loss of amplitude. The time, the velocity is the same, but the amplitude is decreased. And then if there is conduction failure, at 7 days, we got also the distal potential that is lost because of Wallerian degeneration. When we got total axon loss, of course, sensitive and motor action potential are unreversible because there is total axon loss, and fibrillation potential, on the contrary, are abundant. And motor unit action potential are absent or discrete because there is a total axon loss. If there is complete lesion means no junction, no contact at all. So we're talking about neurotmesis, and so no motor unit action potential. Another things, when we go in the 14th days, usually we see insertional positive sharp wave in a denervating muscle that persists for 7 days and then are replaced by fibrillation potential between 3 and 5 weeks. When we got insertional positive sharp wave fibrillation potential, sometimes we can have a pairing that could be sooner if there is a shorter distal nerve stumps, and somewhat later if we have a longer distal nerve stumps. So general rule, wait to do the first electrodiagnostic study at 4 or 6 weeks to allow the fibrillation potential seen in Sunderland 2nd, 3 and 4 and 5 degree, enough time to declare 10 symptoms, giving you a very helpful tool to get a diagnosis. So after this going over the electrodiagnostic slide, let's take a coffee and let's talk about something a little bit be exciting. That is the timing of nerve repair and nerve repair as well. So the question is time nerve? Well, is time nerve, but in particular is muscle nerve, and let's see why. When we talk about timing of nerve repair, we need to remember this rule was taught by my good friend, Dr. Robert Spinner of Mayo Clinic. That is the 3 and 1 rule. When we have nerve injury, like a be sharp injury, let's examine, let's explore the patients within 3 days. When we got an avulsion, crash, or blunt injury, like could be gunshot wounds, delay the surgical intervention, monitoring the patients for sign of spontaneous recovery, and perform the electrodiagnostic studies at 3 weeks post-injury. For patients with no sign of recovery, or serial clinical examination or electrodiagnostic studies at 3 months post-injury, so the patient came to your attention after 3 weeks and say, I have a weakness, I have a loss of sensation, wait 3 months, and then after 3 months, surgical intervention should be considered. In patients, when we go over 3 months, we need to consider in these patients a safe surgery, like could be nerve transfer, prior to muscular fibrosis and atrophy. This happened at 1 year. So remember this rule, 3 times 3 and 1, like 1 year. And let's remember the definition. When we do in the first 24-hour nerve repair, we consider him like a primary repair. When we do in between 3 days and 1 week, we consider him like a delayed primary repair. So the task should be happening in blunt injuries. And the nerve repair performed after a week is a secondary repair. So what type of nerve repair we can do? Well, we can do several types of nerve repair, but everyone depends by the situation we're considering. So is a matter I hope to tell you in my future panel. But for the beginning, we need to remember that we have as type of nerve repair a direct repair, an indirect repair, and other 2 types, but they are usually safe procedures. They are nerve transfer and secondary procedures. So let's see more in detail. The repair means that we put the proximal and distal part of the nerve involved, and we do a repair, a direct repair without interposition of anything. This is an epineural repair. Epineurial repair is done by this wire, that is a night dose 0 wire usually, and it is the repair needs just a few sutures to have this aspect, so have a correct junction between the 2 stumps of the nerve. Or we can do also in a fascicular nerve repair. In this case, it's very important to have the intraoperative diagnostic stimulation to have a correct fascicular nerve repair that respect the somatotopic architecture we just seen at the first slide. This is the bad way to do repair. In this case, there is not the correct facing of the 2 nerve stumps. and in this case, the fascicular nerve repair is totally wrong. In these two cases, we cannot expect a good outcome. On the contrary, we could expect a neuroma or an unsuccessful surgery. So we don't solve the patient's problem in this way. This is an example of a fascicular repair. And this is a personal case I would like to share with you. This is a case of a man of 50 years old that came to my attention because he got a blunt injury to the left wrist using a bill hook. He suddenly have a hypoesthesia to the first, second, and third finger associated to distal phalanx paresthesia. And in the following weeks, he got a progressive hypotrophia of the flexor pollicis brevis. I performed electrodiagnostic after 10 weeks. In the meantime, I told him to do physiotherapy to move the hand and the finger. But after 3 weeks, I saw fibrillation potential, but no motor reaction potential, transmitted was as a denervation. So the patient got a hypoesthesia, but he saved this palmar aspect of the, in this case, is obviously involved the median nerve. And let's remember a little bit of anatomy of the median nerve. In this case, was saved this part that is innervated by the palmar cutaneous branch of the median nerve. So I was sure that this trauma probably involved the distal part, Rachel Tandes, of palmar cutaneous branch, and so it was also my care to save the palmar cutaneous branch as well. So I performed surgery. This is the intraoperative picture. Let's see more in detail. That's what I just seen. You see here, this well-read speck is a scare. So let's see what's happened when you wait. In this case, it was justified because it was a blunt injury. But let's figure out if we wait more and more time. This is a scar. It was very hard, believe me, and very attached to the epineurium. I spent 1 hour and a half to get free the nerve and get free the nerve from the scar and see the epineurium. This is the pink aspect here. The epineurium was also broken and it was fascicular, but I explored the fascicular and they were alive. By intraoperative stimulus, they were absolutely in continuity. So at the end, I just put some suture to close the epineurium. I was sure the nerve was completely free of scar and was so there was no other scar around the palmar cutaneous branch. And after some weeks of physiotherapy, that's the patient now. He is a passionate bicycle racer in the mountain and is stay very well. He recovered completely the sensitive aspect of this aspect, some paresthesia to the apex of the finger, and the flexor pollicis brevis recovered completely. Indirect repair. Indirect repairs means what? That in this case, we got a nerve with or a neurotomesis with a retraction of proximal distal part, or we got a neuroma in continuity. This is well defined by histological section. This is proximal distal. It is well defined, but here there is a completely lost of architecture. So in this case, we have to do that. We have to do the also called bread loafing. So we need to cut the neuroma and check when we find again fascicle. So doing that, we are able to remove the neuroma in continuity and have the two stumps that are able to reinnervate. And we need so an autograft sometimes because the nerve is able to the two stumps of the nerve are able to connect him just for a few millimeters, usually 5 millimeters. Now, if we go over and we doing a traction against the of the stumps, the recovery won't happen, because traction means ischemia for the proximal distal, and so no renervation. In this case, so we need autograft. This is a direct nerve repair. This is the indirect repair, and this is the graft. So it's an interposition of nerve. So where we can find the nerve? The nerve, let's see. In the meantime, let's remember that the autograft nerve has the advantage to be immunogenically inert and a viable source of Schwann cells to facilitate axonal regeneration. And nerve graft of less or equal to 6 centimeters are the most reliable. So we got a large gap we can fill in with nerve graft. And small thin graft have better functional outcome. That's because they are little, and so they have a more easier revascularization. Remember that bigger is the autograft, less opportunity to revascularization, so of renervation there are. The drawback is that autograft nerves means a second operative site, so it could be donor site morbidity, additional scarring, and the potential of painful neuroma, and obviously added operative time for a graft area. But it's the best graft we can find, because usually we find the graft, in this case we got a superficial radial repaired by a graft, and we can see here immediately how the outsource, in this case I think it was Susan McKinnon, put the nerve not like a can I say, they give him some curves. That's because reduce the tension between the two stumps of the nerve and allow the patient to move his finger without creating tension on the two stumps. The graft can be found usually in the in this case it was taken by a medial anterobrachial cutaneous branch, but I prefer use in my daily activity the sural nerve. Sural nerve is that's because it is more I've got more practice to perform a graft from sural nerve. It's very simple to find in, because using this technique to finger breadth behind the lateral malleolus and to finger breadths over this point, we can do a cutting here, and we're able to find the sural nerve. And then the sural nerve involve the feeling, the sensation of just this part, lateral part of the foot. And so is very comfortable for the patients. They go just some paresthesia to this part, but usually paresthesia recover very well, in particular in a young man, in a young patient. And then the wounds is in behind here, and so is not visible, like could be in the forearm. The allograft nerve are an alternative to the autograft nerve, where we don't able to do an autografting. Allograft means that the nerve is taken by a cadaveric donor. The advantage is no need for a second operative site, and regeneration is equal to that across a nerve autograft. So why we don't use always allograft? Because there is a drawback, that the patients need immunosuppressive therapy. Remember that in allograft nerve there are the Schwann cell. The Schwann cell are can give rejection. So the patient for the first 6 months need immunosuppressive therapy with all the risk related. And so that's the reason that allograft nerve don't have so great success, or no success more than the autograft nerve. This is an example of autograft nerve. And this was happened when we put an autograft nerve. It happened that the allograft nerve give a direction to the Schwann shell to migrate and to recreate this connection. So when we, the Schwann cell are able to recreate the wall gap, the immunosuppressive therapy could be withdrawn, and so that's the only reason to prefer the autograft than the allograft. An alternative is use a cellularized nerve allograft. So in this case, the allograft was treated to remove the immunogenically active part, so the Schwann cell. So in this case, no need of immunosuppressive therapy because there is no rejection risk. But the cellularized nerve allograft is inferior to allograft in terms of regeneration, and suitable for short gap, less than 3 centimeters. And that's because the Schwann cell, even if by the cadaveric donor, have a role. Another solution is to use the nerve tube and nerve conduit. Nerve tube and nerve conduit are this material that consists in hollow luminar or filament containing, sponge containing, multi-channel. They give a route to the axonal regrowing fiber to find his target, his distal stump of the nerve. There are some examples of nerve conduit. They are usually done by some specific material like polyglycolic acid, or we can also find among these this material that is an axoguard nerve connectors. It is put in this way. This is a cadaveric specimen I did in one of my courses in Denmark. I cut this digital nerve and I rebuild him using this nerve conduit. It's just needed to suture in both the stumps, and the gap should be less than 5 millimeters. Nerve transfer, I give you a brief description because it is a very long topics, and I prefer to talk in another panel, but let's have a look. Nerve transfer is not actually a nerve repair, but is a nerve saving, and it usually consists in using a vital nerve and connecting to the nerve that need reinnervation. The most common nerve transfer is the triple transfer in a brachial plexus lesion. That could be, in this case, a baby with obstetric brachial plexus paralysis. It consists in the recovery of extra rotation of shoulders using a branch of the accessory spinal nerve. The trapezius is innervated by accessory spinal nerve, receive a double innervation, so we can use one of these to connect to the suprascapular nerve in this fashion, and the trapezius usually don't go in atrophy at all, even because we're talking about a very young little patients. The second transfer usually consists in use a branch of the tricep brachii, is usually from the radial nerve, and connect to the axillariosyncophlex nerve to recover the deltoides, so the abduction of the shoulders. And finally, with the Oberlin transfer, using a branch for the flexor carpi ulnaris, we are able to reinnervate the musculocutaneous nerve and so the bicep brachialis, and give this poor baby the elbow flexion. So the patient is with this nerve transfer is able to recover the most part of his upper arm movement. So nerve transfer could be done until 1 year since the nerve lesion. After 1 year, the muscle go in atrophy, and so nerve transfer could be not efficacious. In this case, what we can offer to the patients, just secondary procedures that are sometimes very efficacious. In this case, is a patient with hands drop caused by a radial nerve injury. So a patient is not able to extend the wrist. In this case, what we can do if we're gone over 1 year, we can do this secondary procedure. Use, in this case, the pronator steres that is innervated by the median nerve, and doing a tendinography to the extensori carpi radialis brevis, extensori carpi radialis longus. Using the palmaris longus, always innervated by the median nerve, and doing a tendinography to the extensor pollici longus. And finally, the result is this. The patient is able to, using this muscle, not involved because they are innervated by another nerve, not the radial, but the median nerve, is able, by physiotherapy, of course, to extend his wrist. And then finally, physical therapy. As I just told, patients need physical therapy after nerve surgery. And physical therapy could be started immediately due to lack of tension with either primary nerve repair or nerve grafting. The movement of adjacent joint is not contraindicated at all. There could be also very helpful the use of splinter, in particular in little baby, for a maximum of 7 days. And the patient's then the splint is removed, and the patient allows gentle range of motion. If anyway there is also a tendon transfer, the immobilization is longer to protect the tendon repairs. So 7 days is a few times, and need more time to get a complete repair. That when we talk about physical therapy, sometimes the nerve injury associated with other injury, like in this case, there is a clavicle injury, dislocated and pushing against the brachial plexus. So in this case, the patient needs physiotherapy, but physiotherapy needs to be tailored on the presence of a clavicle fracture fixed. And last but not the least, remember that a scar formation with physical therapy could be elongated and so allow neurogliding. So we finish here. I show you my reference, my preferred book for the basis of nerve surgery. This is Suna McKinnon and Manual Peripheral Surgery, and the section of humans about peripheral nerve. And for electromyography, that's my preferred book that I used during my master in electromyography. That is the Preston book. So thank you everybody for your attention.
I'm sorry, Marco. Excellent. Excellent. I'm not a neurosurgeon, but I trained a little bit in orthopedics, and those guys do a lot of that stuff too. Really interesting. I'm sure the panel found it very, very interesting. And so I'm going to open up the panel for comments or questions, and I'll just let me bump you off the screen share.
Yeah. Can I do? Sorry.
Did you want to show something? I can take you off right there. Right.
No, it's okay.
Okay. Question: did you want to show something, or are you?
No. I'm out of sharing, right?
Yeah.
Okay, perfect.
So yeah, I'm just trying to get some questions or comments. Okay. Any questions or comments from the panelists? We have a lot of panelists. About 30.
Dear Dr. Bennett, may I make a comment?
Yeah, go ahead. Go ahead.
This was a very nice presentation for Marco, from our friend Marco Melloni. We need really to thank him. For many years, and still now, the peripheral nerve for the neurosurgeon is a kind of dark side of the moon. Because in our training, we have, I think that Marco agrees, we have to learn many things and we have to do many things. And peripheral nerves remains less, less a part less training and a less actual practice of the current neurosurgery in all over the world. One small comment, Marco show us some interventions that he made in small children, and maybe these interventions, I don't know, it is a question to Marco, maybe they need also assisted by, yes, by a neurosurgeon, but also from combination with orthopedic, pediatric orthopedic, because it is the for a small child.
Correct. About your last question, peripheral surgery usually is a multidisciplinary surgery.
Okay.
Because sometimes, in particular, when we talk about injury, these injury are associated with other injury, like could be bone injury, vessel injury. So in this case, it's needed to have a multidisciplinary team. So it's not conceivable a peripheral nerve injury unity is created by just one neurosurgeon. Neurosurgeon need to have a referral vascular surgeon, need to have an orthopedic surgeon, need to have also a plastic surgeon. Just figure out in a baby with obstetric brachial plexus paralysis, the helpful of the plastic surgeon is absolutely unrenounceable. So that's also because the peripheral nerve surgery is, as you just told, the dark side of the moon, because is a matter that is quite different from the orthodox neurosurgery. Is another anatomy, is also another type of surgery and another type of knowledge, because we need to know definitely about the approach nerve lesion, how to talk about electrodiagnostic exam, and so you need definitely a long learning curve. Absolutely. But I think the importance of peripheral nerve surgery for a neurosurgeon is also cannot be cannot be put in doubts. There are no doubts about the need for a neurosurgeon to know about peripheral surgery, because sometimes a patient with symptoms that could be neuralgia to the upper arms have a diagnostical differentiation with some peripheral nerve pathology. I got a lot of, I saw one times a patients with foot drops. I remember this patient was operated for a heart bypass, and he got foot drops. He performed a lot of MRI to check if there was hernia, stenosis, physiotherapy, was not able though to find a solution for his foot drops. It was needed for me just to ask the patients to drop his paint, and I found what's a socker in his knee, a shoulders to anti-thrombotic socker that push against the common peroneal nerve. So first thing I ask the patients is, how long do you have this socker? Well, 3 months, doctor. Okay, just remove the socker. After 2 months, foot was able to move again. So in this case, differential diagnosis was very, very important for me because I examined the patients and I found there was not a spinal problem, but a peripheral nerve problem.
Thank you very much.
Very good. Thank you, Marco. Okay, next comment or question. Did you have another question, Nick?
Yes, yeah, no, another else.
Oh,
Thank you very much.
okay. More comments, questions from the panelists?
No one.
Go ahead. I heard someone. Well, someone's going to have a question. I know
Hello?
you do. Go ahead. Go ahead.
Hello?
Go ahead.
Yeah, this is Yanga from Uganda.
Welcome.
Yeah, I want to ask a question. Thank you so much for this presentation. And my question is, after the repair, the nerve repair, at exactly what time we start physiotherapy after nerve repair? Like for this example, shown here in the presentation from the Dr. Meloni.
Well, usually as soon as possible, because nerve repair is just the first step. Then the nerve need to regrow in 1 millimeter every day. But as soon as you start physiotherapy, there are more opportunities to stimulate the nerve and allow him to regrow. So start as soon as possible. When I operated these patients, you saw in the slide of nerve repair, I waited just 1 day, and the day after I told this patient, let's start to move your arms. Of course, it depends also by the surgery you perform. If you perform a brachial plexus surgery, you can ask the patients to move the day after his shoulders, because there is a pain of surgery. But if you wait just a few weeks for the post-operative period and then start with the physiotherapy.
Marco, you want to go into peripheral nerves as a specialty, right? In neurosurgery, or you want to do a fellowship in it?
Well, actually not. Actually, I spent about 1 year in London, in the United Kingdom, like visiting surgeon in a peripheral injury department. So I saw a lot of surgery, peripheral surgery, participate as a second operator, and then I usually go to a cadaveric dissection course in Denmark in particular. There is a very interesting course of peripheral nerve dissection, and I recently I've been in Michigan and Minnesota to see the nerve transfer. So that's my learning curve.
Very good. Okay, more comments, questions? The floor is open. There's Dr. Cabullo.
Yeah, hello, sir. Hello.
You know Dr. Cabullo, right, Elhanga?
Yeah, I know him. I know him.
There he is, right there he is. You may be taking a tea break now.
Yeah, I saw him. I saw him, and I want again to know
Go ahead.
if after trauma, the nerve, we realize that the nerve has become like too short. Do we need to extend, or maybe Dr. Meloni has an advice on that? Do we have to extend the nerve so that to pull the two stumps, to pull them and to repair, or there is another way to do for repair?
Well, you can do that if you, but you remember that you cannot move the stumps of the nerve more than 5 millimeters. because in this case you put in tension the nerve, so you you got ischemia to the nerve, and the regrowing is very is very difficult. So first of all, you need to check if you are able to put the stumps without tension. If there is tension, you need to perform an neurograft. So you need to take the usually the sural nerve, or if you're working in the forearm and you're close to the medial antebrachial cutaneous nerve, you can also use that, so you avoid the patients to do a second wounds, and repair by grafting.
Very good. Did you want to, more questions, comments? This platform is made for interaction. Okay, there we go. Go ahead. Someone's stepping forward there. I don't know if you're muted or not. Go ahead. Did you want to talk? Well, there's a learning curve with this tech. It takes a while sometimes. Okay.
We got maybe some right.
Yeah, if someone has a question, here's, oh yeah, okay. You've already answered that one.
Okay, use of presentation when one shows start physiotherapy after wrist tendon and medium nerve repair. Well, usually after you perform about the repair, I have just told you can perform the physiotherapy as soon as possible. But when you do a tendorrhaphy, so a tendon transfer, usually you need to wait. Usually, I think 1 month at least, 3 weeks, 1 month. You cannot start the physiotherapy immediately after a tendon transfer.
Okay, very good. Any more comments, questions? Okay, Marco, I guess we're going to do a series, right? That's a, do you know how many are going to be in the series?
Yeah, I don't know exactly what's the exact number of series, okay. But it's my intention to cover the upper and lower extremity, and dedicate some section to the specific topic, like could be the use of sonography, as was another of my interest, is sonography in peripheral nerve injury, and the nerve transfer. And then if for the panelists could be helpful, if it is not exactly neurosurgery, also the secondary procedure in a patient with nerve injury, that could be tendorrhaphy, but let's see in course of working.
Okay, very good. Okay, thank you very much, Marco. Thanks for being patient, waiting around. And
thank you to be patient with my presentation.
Okay, we're going to move on next to a talk by Victor Hugo Perez Perez. He's a well-known anatomist from Mexico City that I first was introduced to him by an El Salvadorian neurosurgeon, Cesar Wandique. And Victor has done a lot of webcasts on neuroanatomy, and neuroanatomy is his passion, and you'll be able to tell. So, okay, welcome, Victor. It's all yours.
Thank you, John. Okay.
Sorry, we're a little late, Victor.
Is ready?
Yeah.
Okay. Let's go to have a picture, have a lecture. This is a short lecture. I want to show you some pictures and some videos about the middle cerebral artery. I have been doing this work for about 32 years. So this kind of brains have been injected in fresh cadavers. So that's the reason we can see the detailed anatomy of the brain. Some of them have been injected in situ, but other ones they have been injected. Can you hear me? Yes.
Yes,
John?
yes, yes,
Can you hear me?
yes, we can
Okay.
hear you.
So this is a brain injection in out of the corp, of course. So I am injecting silicone in the middle cerebral artery. So we can see in this video the cortical arteries of the middle cerebral artery. This is the M4 segment. So this is a beautiful video because you can see arteries from the tip of the temporal lobe until the tip of the frontal lobe. So these cortical arteries have been described very, very well by Dr. Roton. They are almost 12 arteries in the cortical segment of this beautiful artery. The middle cerebral artery is very important because in a surgical approach, you should know that this middle cerebral artery has several segments, and we need to avoid damage for this artery. This is the right side of this brain. In here, there is a small rupture of the artery, but I try to insist in injecting this brain in order to fill out these small arteries. So it doesn't matter if there is a rupture in these arteries. So I try to push the injection in order to have a nice feeling of the silicone in these arteries. This is another picture. We can see in here the supraclinoid carotid artery. We know that this segment has three arteries. The first one is the ophthalmic artery. The second one is the posterior communicating artery. Here it is the posterior piscicum. And this one is the anterior choroidal artery. And then we have the bifurcation of this carotid artery into branches. The anterior cerebral artery and middle cerebral artery. Middle cerebral artery is the largest artery and the big artery in the brain. This is almost 4 millimeters, almost twice for the anterior cerebral artery. Here we have the optic nerves, the mammillary bodies, the infundibulum, cranial nerve, basilar artery, This one, the superior cerebellar artery and posterior cerebral artery, first and second segment. The middle cerebral artery is the largest and most complex of the cerebral arteries. Some of its branches are exposed in most surgical procedures in the supratentorial area. In the past, surgical interest in the middle cerebral artery has been directed at avoiding damage to its branches during operations within its territory. But microoperative techniques have now made reconstruction of and bypass to the middle cerebral artery to preserve and restore blood flow to the cerebrum. Here we have the frontal lobe, temporal lobe was cut, was removed, and we can see here the first segment of this middle cerebral artery and second segment, third segment, and fourth segment. This is the sphenoidal segment, M1, M2, insular segment, M3, opercular segment, and M4, cortical segment. The middle cerebral artery arises as the larger of the two terminal branches of the internal carotid artery. You can see it here. The diameter of the middle cerebral artery could be from 2.4 to 4.6 millimeters, almost twice of the anterior cerebral artery. Its origin is at the medial end of the sylvian fissure in here, lateral to the optic chiasm. Here we have the optic chiasm, lateral is the beginning of this middle cerebral artery, and below the anterior perforated substance. As it passes below the anterior perforated substance, like here, it gives rise to a series of perforating branches referred to as lenticulostriates arteries. In other pictures, we are going to see these beautiful, very beautiful arteries. I am impressed about these lenticulostriates arteries. This middle cerebral artery is divided in 4 segments, M1, M2, M3, and M4, sphenoidal, insular, opercular, and cortical branches, or segments. The M1 begins at the origin of the middle cerebral artery, M1, here, and extends laterally within the depths of the sylvian fissure, terminates at the site of a 90-degree, this is 90-degree turn, this one. So this artery terminates in this turn, not in the bifurcation, in this turn. So the henu located at the junction of the sphenoidal and operculo-insular compartments of the sylvian fissure. This segment begins at the henu, where the middle cerebral artery trunk passes over the lumen insulae and terminates at the circular sulcus of the insula. This is the second segment. The branches to the anterior frontal and anterior temporal areas cross by anterior part of the insula. The M3 segment begins at the circular sulcus of the insula and ends at the surface of the insula and ends at the surface of the sylvian fissure. This is the sylvian fissure. Why you see this aspect of the cortex of brain? Can you tell me what is the reason you see this brain in this aspect? Okay, in here I remove the gray substance. So we are seeing in here the white matter of the brain. This is the sylvian fissure, And here we can see the M1, M2, M3, and M4. M3 segment, the branches directed to the brain above the sylvian fissure, like here, undergo two 180-degree turns. The first turn is located at the circular sulcus, where the vessels coursing upward over the insular surface turn 180 degrees and pass downward over the medial surface of the frontoparietal operculum. The second 180-degree turn is located at the external surface of the sylvian fissure, where the branches complete their passage around the inferior margin of the frontoparietal operculum and turn in a superior direction on the lateral surface of the frontal and parietal lobes. This picture is just to see M1, M2, M3, M4 cortical branches. But this is also to see optic nerve, the optic chiasm, and this nerve tract. The M4 is composed of the branches to the lateral convexity. They begin at the surface of the sylvian fissure and extend over the cortical surface of the cerebral hemisphere. The more anterior branches turn sharply upward or downward after leaving the sylvian fissure. The intermediate branches follow a gradual posterior incline away from the fissure, and the posterior branches pass backward in nearly the same direction as the long axis for the fissure. Okay. Look at this. Here we have the olfactory nerve, olfactory tract. This M1, supraclinoid carotid artery. This is a optic nerve, optic chiasm, optic tract, this one, and these beautiful arteries that are arising from M1 segment. So this is a block of brain that was dissected, removing the gray substance. We can see here the white fibers, the white matter, this one. And here we have the M2 segment of the middle cerebral artery. This is a cortical artery. It is the M4 segment. Another one. M1, M2, can you hear me, John? Yes.
Yes,
can
we
you hear
can.
me? Yes.
Yes, we can.
Okay. M2, M3, M4. In this view, you can see why this artery is considered the largest one, because it's the beginning, and then look at this main trunk of this middle cerebral artery. Here it is, here, 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 and here, and then ends in the occipital lobe. Look the trajectory of this artery is the largest one. The perforating branches of the middle cerebral artery and the anterior perforated substance are called the lenticular striates. This one are the lenticular striates arteries. Lenticular striates branches arise from the pre-bifurcation part of the M1 in every case, and from the post-bifurcation part of the M1 segment. Pre-bifurcation and post-bifurcation. Of the total number of lenticulostriates branches, approximately 80% arise from the pre-bifurcation part of the M1. Most of the remainder arise from the post-bifurcation part of M1, and a few arise from proximal part of M2, near the genu. Let's go to see this video about the lenticulostriate arteries. They are in three groups: medial, intermediate, and external group. These are medial. This one is also, this is just a question. Is this artery considered lenticulostriate artery, this one? And what about this? Look, this artery. It is going to choroid plexus. So this artery is known as anterior choroidal artery. Here we have A1, and this is a small artery. Small branches to the optic nerve. Okay. The cortical area supplied by the middle cerebral artery is divided into 12 areas. Orbitofrontal area, prefrontal area, precentral area, central area, anterior parietal area, posterior parietal, angular, temporooccipital, posterior temporal area, middle temporal area, anterior temporal, and temporopolar area. So we should know that anatomy is not the same as pathological anatomy. So we should know what to do in case of great lesions like this. This is a meningioma that is displacing these branches, middle cerebral artery, anterior cerebral artery, and also the supraclinoid carotid artery. So we should have care in order to avoid damage to the brain. So if we do a very care surgical procedure to remove this meningio, we could have a very nice result. So in this case, I was removing this tumor, very big tumor, And at the end of this surgical procedure, we can see this artery. Look at this. This is the supraclinoid carotid artery, anterior and middle cerebral artery. So patient did very well, and the tumor was removed totally. This is a pre-surgical axial tomography, and this was in the postoperative image. This is another picture. We can see in here the supraclinoid carotid artery, middle cerebral artery, bifurcation. To remembering, I like you to remember that the beginning of this artery is in the bifurcation of this supraclinoid carotid artery, and the end is in this 90-degree turn. So this is known as pre-bifurcation and post-bifurcation M1. And in this, we have the pons, the mesencephalon, the third cranial nerve, fourth cranial nerve. Here we have the posterior cerebral artery, and this is the P1 segment of these posterior cerebral arteries. Optic nerve, optic chiasm, and this is the mesencephalon. This is a close view of this. So this is a short lecture, but I think you can see the text. The text was taken of article of Dr. Rotten, and all the pictures, all the and videos are mine. So this is another nice picture. When you make a dissection in a brain, I think that you can learn so much, not only anatomy, but also how to do a surgical procedure. Doing dissection, you can get some abilities to make surgery. So I think in other lectures we can see another arteries. I think short lectures you can make collection of each artery, and you can see when you have some doubts about this artery. My main objective is to show you small videos in order to understand this complex anatomy of the arteries. So thank you so much. I don't know if you have any question.
Yeah, well, thank you very much, Victor. I'm just getting your page up here. I've seen you're very passionate about neurosurgery. You can hear me okay, Victor?
Yes,
Yeah,
of course.
okay, and let me just open the floor for comments or questions. Any comments or questions from the panelists? Don't be afraid.
Gracias de nuevo.
Go
Hola,
ahead.
¿me escuchan?
Go ahead. Ándale, pues.
Hola. Buenas tardes, doctor Víctor, doctor John y doctor Marco. Muy buena presentación y muy excelente trabajo que profesores lo mostraron ahora. Y bueno, para mí es muy interesante verlo esto y aprender Y me gustaría otro momento también que usted nos da esa charla sobre cada arteria. Eso sería un placer y durante ese tiempo de COVID podemos adquirir esas habilidades, ver cada una de arteria y aprender. Muy interesante, muy interesante. Muchas gracias.
Yeah, but it's much better your language. I know that you are from Syria. Are
From
you
Pakistan.
Syrian? Pakistan. So
Pakistan.
much better your Spanish.
Gracias.
Better than mine.
No, 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 profe,
Thank you,
no.
thank you.
Bueno, muchas gracias. John, gracias a ti también.
Okay,
Nos
Andale.
da plataforma para hablar.
Muy placer. Otra preguntas, comentario, or others questions or commentary? Yeah, I was going to ask you, Victor, do you have any quick videos you can show them latex injection? Or that's a long video?
Which one?
You have a short one you can, because I think some of the people have not seen your latex injection.
Okay,
Could
okay,
you
let
show
me
us
see.
one to give them an idea of how great it looks?
Yes, of course.
Yeah, and explain how
Le-
it's
le-
done and how painstaking, how time consuming it is.
Yes, yes, of course. Let me.
It's a bonus that people won't have to pay for this. It's a bonus.
Yes, I think so. Yes. So I think this is let me show you some of
Okay.
these. For example, in okay. Wait a minute. Okay, just okay. For example, I think that it has been done too much work about injections of brain, but in the spinal cord, I think there is no much work in this area. So this is an injection of spinal cord in the venous system. So these videos are very useful for the spine surgeons or especially.
Does this have to be a fresh cadaver? Victor?
Yes, it was made in fresh cadaver.
Okay.
This is a very laborious work because first of all, you need to remove all the spinal cord, and it's not easy. You have to cut all the vertebrae, all the laminas in the back of the corpse, and then after to remove this spinal cord and then to inject. So you have to wash very good the veins and also the arteries before you inject them. But the results are very nice.
Yeah.
Like in this video.
That's the actual anatomy.
Yes, I think they are very nice. So let me show you another one. Let me let me see this one. This okay. Okay. Let me put this one. This is maybe a very heavy here I am cutting the oncos, the medial part of temporal lobe. I need to be careful in order not to damage other arteries and nerves. So this is good because we can see the optic nerves, optic chiasm, supraclavian carotid artery. This is the posterior communicating artery and some branches. This one is the anterior choroidal artery. Was good in order to see the optic tract. So I think these videos are useful for neurosurgery residents. So I think that we can work in several topics of vascular anatomy and also anatomy of the brain, parenchymal brain.
Okay,
Yeah.
Okay, very good, Victor. I'd like to thank you very much. Sorry it took so long. Hope we didn't take up too much of your day. And we look forward to seeing you. You'll be speaking in Saudi Arabia, correct? On that conference in Saudi? There's a neuroanatomy conference, I believe.
Yes, with Dr. Ahmad Khanan.
Right, the 12th
Yes.
and the 13th.
Yes,
We'll be televising that.
Yes, I'm going to talk about veins of the brain.
Oh, okay.
The venous system.
Very good. We'll be seeing you then. Okay, Victor. Muchas gracias.
Thank you so much.
Okay, ciao, everybody.
Ciao, ciao.
Bye-bye. Okay. Yeah, the first conference, Victor, went really long. Yeah, what can you do? Everybody, all the speakers are going, we say 20 minutes, but they're going 30, 35.
No, I think that if you do, for example, anatomy is heavy. Anatomy is heavy. It's not easy.
Fixed.
So anatomy is much better to give 20 or 30 lectures in order to understand, because anatomy is heavy. Most of the people don't want to take anatomy classes.
Yeah.
But I am trying to make this different with videos or videos or pictures. I think much better. What do you think, Marco Meloni, about the short lectures in anatomy, exclusively anatomy?
Go ahead, Mark. Mark, are you there, right?
Yeah, I'm here. Well, Dr. Bob, I think they are absolutely amazing. Neuroanatomy in particular for the neurosurgeon is need to be interactive, need to be three-dimensional. So study the neuroanatomy by book is definitely the basis. But then we need to see in a three-dimensional way. We need
Yes, yes.
to have also, and that's I think the best, to have the neuroanatomy explained by a neurosurgeon. So
Yes.
one like your that understand what are what's need a neurosurgeon to know. So I absolutely, they are very beautiful. I appreciate a lot your lesson, and they are absolutely useful. And I encourage you to carry on this presentation, because
Yes.
they are
Your lecture was interesting. I followed it. A complete lecture. You do nerve surgery. Where are you from, Marco Meloni? Where are you from? Where? From
Italy.
Italy. Ah, okay. Yeah.
North.
Okay. You live in Italy.
North Italy. Yeah,
Yeah,
North
yeah.
Italy.
Yeah. Oh,
Close to
yeah.
Lake Como, right?
Lake Como. I was in
Yeah.
Lake Como. I was in Lake Como in the surgery Eurospine Congress. It was made in Milan. It was held in Milan, Italy. So really, really nice place. But now, badly, one of the places that was hit by COVID.
Yeah, he has some good stories about that. He has some stories about that. Is it still really bad there, Marco? Is it still locked down and everything, or is it getting better?
Well, now is a little bit better. We are in our government started the second phase. Second phase means that some activities are open, like could be some, for example, since until today we're not allowed to move in other town. For example, my girlfriend work in Milan, 1 hour of car from me. I cannot see her since 2 months.
Wow! Wow! Wow!
Yeah.
It's
Now,
incredible.
yeah, very hard, very hard. Now we're able to move in by town to another town inside the same region. So I cannot, for example, back to my parents in Sardinia, because I was born in Sardinia, in one of the islands of Italy. But I can see again my girlfriends, because we are in the same region.
Wow.
So this is the second phase. We need to stay 2 weeks. If there are not increasing of contagious, we cannot go to the third phase, and so there's going to be a reopening of the restaurant, of some crown activity, but with some protection. So everyday mask, everyday distance.
Yes.
So finger crossed, and let's hope during the following 2 weeks there are not more contagion. On the contrary, I think the things can be even worse than before. So let's pray.
Getting better. That's good.
I hope. Thanks.
Yeah.
Okay, everybody, we're going to end this. And Adnan, thanks for coming. Thanks, Victor. Thanks, Ahanga.
Una pregunta.
Okay,
Sí,
go ahead.
John,
Go ahead.
Profe Víctor, ¿cuándo es la próxima charla de usted con los de Arabia Saudita?
It's 12 and 13 of this month. So I think Dr. John Bennett has published the
Sí, Adnan, nosotros vamos a televisar
Yeah.
un congreso de 12 y 13 ese mes
Ok,
de
está bien.
Saudi, neuroanatomía puro. ¿Verdad, Victor? Dos
Sí, está
días
bien.
de neuroanatomía, ¿verdad?
Yes.
Okay.
Muy
Nos
bueno.
vemos en este tiempo. We'll see you in that
Bueno,
time.
nos vemos. Muchas gracias. Nos vemos.
Okay, ciao,
Thank you.
everybody. Have a great day.
Bye.
Thank you.
Thank you. Bye.
Bye-bye.
Bye.
Let me get this.